Greetings and welcome to what promises to be one of the most exciting sessions of Kidney Week Reimagined. I'm Dr. Deidre Cruz, a nephrologist at Johns Hopkins University, and I'm joined by my co-moderator, Dr. Linda Audeshu, who is professor and chair of clinical pharmacy at the University of California at San Diego. As members of the 2020 Kidney Week Education Committee, we are very pleased that you've joined us for this session on high-impact clinical trials. And these are trials that are expected to have significant impact on clinical practice. We have 8 wonderful presentations that are scheduled today, and each presentation will be for up to about 10 minutes, followed by 3 to 4 minutes for Q&A. In order to submit your questions, please use the Q&A feature. And if you have comments and things that you would like to share with one another, you may enter those in the chat function. And so our first presentation will be delivered via video by Dr. Rajiv Agarwal, who is professor of medicine in nephrology at Indiana University. And this title is on the effect of finerenone on chronic kidney disease outcomes in type 2 diabetes.
Hello. I'm Dr. Rajiv Agarwal, Professor of Medicine, Indiana University School of Medicine, and staff physician at the VA Medical Center, both in Indianapolis, Indiana, USA. On behalf of the International Investigator Team, the Executive Steering Committee, and the Principal Investigator, Dr. George Bacris, I'm here to present the results of the FIDELIO-DKD trial. Dr. Bacris and I will be taking your questions, so here are our disclosures. There are 7.6 billion people on our planet, of which more than 800 million are estimated to have CKD. It is estimated that globally 3.9 million people receive kidney replacement therapy. More poignant is the fact that as many may die due to lack of access to kidney replacement therapy. Diabetes is a leading cause of CKD worldwide. The mainstay for the management of patients with type 2 diabetes has been the blockade of the renin-angiotensin system. The kidney protection was noted in the RENAL trial, in which losartan protected the kidneys, and recapitulated in the IDNT trial. That was in 2001. In 2019, a role of canagliflozin was discovered among patients with type 2 diabetes and CKD in providing kidney protection. Nonetheless, patients with CKD and type 2 diabetes remain at high risk of kidney failure and cardiovascular events despite these treatments. An unmet need still exists. Current therapies predominantly have hemodynamic and metabolic effects and do not target the inflammatory and fibrotic drivers. The rationale for FIDELIO-DKD trial focuses on the mineralocorticoid receptor, which I will call MR. Overactivation of MR causes inflammation and fibrosis. Finerenone was discovered by screening over 1 million compounds to discover one that was selective to MR. In other words, it did not talk to the sex hormone receptor, just the MR. Unlike the current MRAs like spironolactone or eplerenone, it is not steroidal in nature, and that is why it is called non-steroidal MRA. Numerous animal studies have shown that it has potent anti-inflammatory and anti-fibrotic effects both in the kidneys and the heart. More important, in patients it improves albuminuria independent of blood pressure, as shown in a phase 2 trial called ARTS-DM. In FIDELIO-DKD, we hypothesized that the MR antagonism with finerenone would slow kidney disease progression and reduce cardiovascular morbidity and mortality in patients with advanced CKD and type 2 diabetes. We included patients with diabetes with an eGFR between 25 and 75 and moderately to severely elevated albuminuria. We included patients who had serum potassium of 4.8 millimoles per liter or less. We excluded patients with symptomatic heart failure with reduced ejection fraction. FIDELIO-DKD, together with its ongoing sister study, FIGARO-DKD, formed the largest clinical trial program in patients with CKD and type 2 diabetes. The trial included a run-in period of 4 to 16 weeks, during which time RAS therapy was optimized to a maximally tolerated labeled dose. 5,734 patients were randomized 1-to-1 to finerenone or placebo. The endpoints included a primary kidney composite and a key secondary cardiovascular composite. Further hierarchical endpoints are listed here. Studies like this require a global effort, 48 countries, more than 1,000 sites, and 99.7% completed the study. Mean age was around 66, blood pressure 138/76, 99.8% of patients were on RAS blocker at baseline. Glycemic control as assessed by A1C was good, 2/3 on insulin, 5% on SGLT2 inhibitor. Mean eGFR was around 44, and over half had eGFR below 45, and almost 90% of the patients had severely elevated albuminuria. First, we'll look at the effects on UACR. Finerenone provoked an additional 31% reduction in albuminuria at month 4, and this was sustained over the trial. The improvement in albuminuria was despite only modest effects on blood pressure, and there was no difference in A1C. And now the primary endpoint, the kidney failure outcome. In the placebo group, 600 patients experienced the kidney failure endpoint compared to 504 in the finerenone group. This is an 18% relative risk reduction with a highly statistically significant p-value of 0.0014. The individual components of the primary endpoint show that all kidney failure outcomes were reduced and the point estimate of the components trended to favor finerenone. The key secondary endpoint was cardiovascular. The number of patients with this event in placebo group was 420 compared with 367 in finerenone group. Relative risk reduction, 14%. P-value less than 0.05, indicating a cardiovascular benefit of finerenone. The third pre-specified hierarchical endpoint was all-cause mortality. Although the hazard ratio was less than 1, this was not statistically significant. Therefore, all other endpoints that were below this were not formally tested. But of great interest, a secondary kidney composite endpoint included the decline in eGFR of 57% or more, equivalent to a doubling of serum creatinine. Protection from kidney failure is even greater when using the secondary endpoint. These data clearly support the primary endpoint results. Translating these results to practice requires consideration of the numbers needed to treat. For the primary kidney specific endpoint over 3 years, 29 patients needed to be treated to prevent one event, and for the CV endpoint, 42 patients. Finerenone had consistent effects on the primary endpoint components and across key subgroups. Safety in the trial was established by investigator-reported adverse events. Overall, these were similar between groups, as were serious adverse events. Adverse events leading to study drug discontinuation was slightly higher with finerenone, and the most common reasons in the finerenone group were hyperkalemia and serum potassium increases. Mean serum potassium levels were higher with finerenone over the course of the trial. The maximum difference between groups was 0.23 millimoles per liter at month 4. Examination of the number of episodes of hyperkalemia during the trial gives us even a better picture. If a patient had even one episode of an increase in serum potassium, such a patient would be counted as one who experienced an adverse event due to hyperkalemia. However, the clinical impact of hyperkalemia can be better assessed by examining how many patients died or were hospitalized or permanently discontinued study drug. First, there were no deaths due to hyperkalemia, and only a small proportion of patients were hospitalized or permanently discontinued study treatment. As you are aware, acute kidney injury is of concern with MRAs, but AKI adverse events were balanced between groups. Our patients had advanced CKD and were treated with maximally tolerated dose of an ASO-ARB, and except for temporary withdrawal of the study drug, potassium management was at the investigator's discretion. In this high-risk population, finerenone was well tolerated. Overall, treatment-emergent adverse effects was similar between groups. Finerenone led to a mean increase in serum potassium of 0.2 millimoles per liter across subpopulations versus placebo. While there was hyperkalemia, this was easily managed by temporarily holding finerenone, and this worked. Only 2.3% of the patients in finerenone group had to stop treatment because of hyperkalemia compared to 0.9% in the placebo group. Let's put these hyperkalemia results into perspective, first by comparing to Altitude and VA Nephron D studies of dual RAS blockade. The rates of discontinuation due to hyperkalemia are much higher than we see in the FIDELIO-DKD, and as you may recall, these studies failed to show kidney or heart protection. Since finerenone is a non-steroidal MRA, how do our results compare with a steroidal MRA? The AMBER trial included patients with an eGFR between 25 and 45 and treated all patients with spironolactone for resistant hypertension. This trial hypothesized that the use of the potassium binder patomer could increase spironolactone persistence. In this phase 2 trial, in the placebo group that did not get the potassium binder, 23% of the patients had to discontinue spironolactone due to hyperkalemia, and this was just over 12 weeks. This discontinuation rate of finerenone was 1/10 as much at 2.3% over a median follow-up of 2.6 years. To conclude, in patients with CKD and type 2 diabetes treated with an optimized RAS therapy, finerenone was well tolerated and significantly reduced the risk of kidney disease progression by an additional 18%, as well as reducing CV events by an additional 14%. Studies like these are global in scope, require massive teams and close collaboration, but they are about our patients. Therefore, our deepest gratitude goes to the patients and their families. We thank everyone who contributed to the study. Full results of the FIDELIO-DKD are now available online at the New England Journal of Medicine. Thank you for your attention.
Thank you, Dr. Agarwal. And now for our Q&A period, we are joined as well by Dr. George Bakris, who is Professor of Medicine and Director of the Comprehensive Hypertension Center at the University of Chicago, and also a co-author on this work. So there are a number of questions that have appeared in the Q&A, no surprise. So one of the first that I'd like to offer is, one person asked, was there a consistent and durable reduction in proteinuria that was observed in the study?
Well, let me answer that. As principal investigator, we looked at this critically, and we really were trying to see if there would be a consistent reduction, since that's an important endpoint. And the short answer is yes, there was a consistent endpoint, and it was greater than 30%, pretty much across the whole duration of the study.
Great. And then the next question was, were you anticipating a larger blood pressure lowering effect?
You know, the short answer to that is I was, but after looking at the phase 2 trials, which we did, we saw that there was only about 2 millimeters at most blood pressure reduction. So this is not a blood pressure lowering drug. In that way, very different than the steroidal agents. In fact, probably less than a eplerenone.
Thanks. And one person asked, they spoke about a significant subset of patients with diabetic nephropathy lacking overt proteinuria, and they were curious as to why they were excluded. And then also asked, would finerenone also slow progression in patients without proteinuria?
Well, Rajiv, you can answer that.
Yes. So you're right. 87.5% of the patients in this trial had overt albuminuria. So you have almost 13% of the people who did have microalbuminuria. To answer your question better, the FIGARO trial is still going on, in which 62% of the patients who have eGFR more than 60 are recruited, and nearly half the patients there have microalbuminuria. So if you're looking for cardiovascular protection, we're actually going to do a study, which is ongoing and should be announced next year. It's called the FIGARO trial, that is focusing on people who have earlier stage albuminuria and better preserved GFR.
Thank you. And next, the next question was, were any of the new potassium binders used for addressing hyperkalemia for the long-term use of testing finerenone?
I can actually answer that question. So there was just one patient in the entire trial who received the newer binder. Most of the binders were KXLate or calcium resin. There were 10% of the people who received a binder in the finerenone group, 7% in the placebo group after the start of the trial. At the initiation of the trial, less than 5% of the people in either group were receiving a binder. As we said before, the potassium management was left to the discretion of the investigators, so they were free to choose whatever they chose to.
Yeah, when we designed that, we purposely wanted a kind of real world experience rather than legislating what you should do.
Thank you. One question was the safety comparisons all demonstrated markedly lower adverse event rates in the placebo group. How do you account for those differences?
I think in part you have to say that the adverse events and the serious adverse events are balanced. If you're comparing against placebo and the drug comes out better, it suggests that it's reducing cardiovascular events, kidney failure events, MI, strokes, etc. But to be sure, you have to be careful about potassium. You did have an increase in potassium with this drug. So just don't look at all of them. When you use this drug, you still have to manage potassium.
Thanks. And then how does finerenone compare to spironolactone in terms of kidney protection?
Well, there's no head-to-head that has looked at this. All of the studies with spironolactone, primarily because of hyperkalemia and profound blood pressure reduction, are limited by reductions in GFR, and so they've examined changes in proteinuria. There hasn't really been, and it is effective in doing that, obviously, but there's really no head-to-head comparison to do that, and that's why we put in the presentation, and Rajiv showed it to you at the end, the incidence of hyperkalemia with Spiro versus finerenone.
And then we may be coming up on the final question, maybe one or two. In chronic heart failure, higher potassium levels are associated with better survival, and this is thought to potentially reflect optimal titration, though. Do the authors see identical correlations regarding the primary and secondary outcomes that were looked at in this study?
So I can tell you that this study is unique in the sense that you have up to 16 weeks of optimizing the ACE or ARB therapy. And therefore, we are actually recruiting patients who have residual proteinuria after you have optimized the ACE and ARB therapy. When you select out these patients, you're actually making your job more difficult. Second, in this trial, we excluded patients who had heart failure with reduced ejection fraction because in those people, spironolactone would be indicated potentially. So we excluded that. And when you exclude those patients, you actually have less renal endpoints, and that has been borne out by several other trials. So we feel that there is consistency of the effect. There are unique endpoints, the renal endpoint and the cardiovascular endpoint. Both of them were met. The p-value of the first endpoint, 0.0014, and the p-value for the cardiovascular endpoint was less than 0.05. And each one of them was statistically designed to show that p-value and adjusted for multiple comparisons. So those p-values are for real.
Yeah, and let me add, there is a paper specifically dedicated to cardiovascular outcomes that is soon to be coming out in a cardiology journal.
Thank you. I think we'll have to leave it there for questions. Thank you to both Dr. Bakris and Dr. Agarwal.
Thank you.
Thank you.
Much.
Okay, our next presentation will be by Dr. Fayez Zanad, who is professor of cardiology at the University de Lorraine in France. And he will be presenting on inferior reduced empagliflozin and outcomes in heart failure and chronic kidney disease. Dr. Zanad.
Ladies and gentlemen, dear colleagues, I'm really pleased to be one cardiologist among this distinguished panel of nephrologists. And I'd like to share with you today the result of EMPA-REDUCE, a heart failure trial, but according to kidney disease and prevalent CKD at baseline. I am presenting this on behalf of my co-chair, Milton Packer, and the rest of the investigators. The incidence and prevalence of heart failure and kidney disease are increasing. Patients with heart failure with reduced ejection fraction have a poor prognosis, particularly if accompanied by kidney impairment and vice versa. For nearly 2 decades, the only drugs with proven effect for slowing the progression of proteinuric CKD were RAS inhibitors. Within this context, in the EMPA-REDUCE trial, we evaluated the effects of empagliflozin in a broad population of patients with chronic HFrEF with and without diabetes. The population was enriched for more severe left ventricular systolic dysfunction and a marked increase in natriuretic peptides. Remarkably, patients were enrolled down to an eGFR of 20 milliliters, and there was no inclusion criteria based on albuminuria. I'm going backward. Thank you. So this is the trial disposition. There was, can you go backward one slide, please? The trial enrolled 3,830 patients and equally distributed among the two arms of the study. The median follow-up was 16 months, and there was almost no loss to follow-up. The trial has 3 endpoints, 1 primary and 2 secondary. All of them had were tested in hierarchical manner, and all of them were met. You can see that adjudicated CV death or heart failure hospitalization was decreased by 25%, and this was statistically significant. Adjudicated first and recurrent heart failure hospitalization was decreased by 30%. And the key secondary endpoint, which is slowing the slope of eGFR decline, was met also statistically significantly so. Now, this is the depiction of the slope, where you can see that under background therapy, there is an inexorable decline of eGFR in patients with HFrEF, which was slowed by the use of empagliflozin. And you can see that the early transient decline in eGFR, which was seen in some patients, does not deprive patients from benefit of empagliflozin. We have looked at that carefully, and there is no excess rate of acute kidney injury in patients with this dip. This is the major outcomes, kidney outcomes, which is sustained profound severe renal outcomes, which is a decline above 40% of eGFR or below 15 milliliters, or entry in chronic dialysis or renal death. And this was remarkably decreased by 50% overall. We have looked at the consistency with the DAPA-HF, the other twin trial in HFrEF with dapagliflozin. And although in DAPA-HF, the renal outcome didn't come out statistically significant, the totality of evidence shows actually that SGLT2 inhibition decreases robustly 48%, 38% the point estimate of first composite kidney outcome. Now, the focus of this presentation is to share with you the result in patients with and without prevalent CKD. 50% of the patients had prevalent CKD at baseline, and expectedly they were older, they had more frequent diabetes, and they have lower eGFR. And remarkably, whether with or without CKD, patients were remarkably treated with RAS inhibition and MRA. Almost 75% of the patients were taken over some sort of RAS inhibitor, an additional 20% were taken in RD, and 67% of the patients in the prevalent CKD group were taken in MRA. This is the primary endpoint split by the subgroup of patients with and without CKD, and you can see basically there is no difference in the benefit of on adjudicated heart failure hospitalization and CV death, whether the patient had or did not have CKD at baseline. I'm showing here again the same Kaplan-Meier with patients with CKD with the superiority of empagliflozin, and here I am superimposing the patient without CKD, and basically empagliflozin treatment reverted the excessive risk of patients with CKD to the level of risk of the placebo group without CKD. Now, the first secondary endpoint was the time to first and recurrent heart failure hospitalization, the total number of hospitalization. And again, this was consistently decreased significantly so with no heterogeneity across patients with and without CKD. And the third endpoint, which is the secondary, which are the slope, here split in patients with and without CKD. You can see in the right-hand side that even in patients without CKD, there is a decline in eGFR in the placebo group, which is inherently part of the HFrEF progression. And empagliflozin slows kidney function decline in patients with and without CKD and across the eGFR spectrum down to 20 milliliters per minute consistently. This is the modelization of the slope as advised by the FDA guidelines. And you can see that patients with CKD have less of a slowing of the slope. However, slowing the rate of eGFR decline at lower level of kidney function is of high clinical importance. The numerically smaller observed difference in patients with CKD may be clinically even more important than the larger difference seen in patients without CKD. And in this analysis allows an assessment of the long-term effects of treatment on kidney function unconfounded by the presence of empagliflozin. It showed that kidney function after treatment discontinuation at the end of the trial was better if patients received empagliflozin treatment irrespective of prevalent CKD at baseline. And this is the hard outcomes. And again, whether a patient had or did not have CKD at baseline, they benefited equally from preventing hard renal outcome of sustained profound decline in renal function, entry dialysis, or renal death. We went across the large number of components of composite endpoints and a number of different composites and compared the outcome in patient with and without CKD, and consistently in patient with and without CKD, all-cause hospitalization, CV death, all-cause mortality, composite kidney outcome with CV death or heart failure, the composite of kidney outcome or all-cause mortality, and finally the acute kidney injury rate, all were influenced equally with no statistical heterogeneity in patient with and without CKD. We further analyzed the result across a large spectrum of baseline eGFR with quintiles of eGFR down to 20 milliliters per minute. And you can see that the primary and the two secondary endpoints were influenced equally and consistently without statistical heterogeneity across the five categories across the large spectrum of baseline eGFR. Now, when it comes to safety, as expected, there was more adverse events in patients with CKD than patients without CKD. But overall, whether in patient with or without CKD, empagliflozin did not produce any excess adverse event as compared to placebo. And if you look at any one of the adverse events of concern, acute renal failure, volume depletion, urinary tract infection, bone fracture, confirmed hypoglycemia, and genital infection, none of them showed any excess with empagliflozin. Therefore, empagliflozin tolerance was really excellent in this patient population, again, in patient with and without CKD. And this slide, I am putting the result in context, showing the result unproduced with CKD and produced without CKD together with DAPA-HF, but also with DAPA-CKD, a trial dedicated to patients with and without diabetes, but all of them had CKD at baseline. And by the way, you can see the baseline eGFR was almost superimposable with EMPA-reduced CKD patient having 47 and DAPA-CKD 43. And you can see that the point estimates were more or less very consistent across all these trials of heart failure and of CKD in diabetes, non-diabetes. And I have plotted here the results of Paradigm-HF, sacubitril valsartan in HFrEF patient, where there was also superiority of sacubitril valsartan as compared to enalapril, but the result was much less impressive than with SGLT2 inhibition. So these are my conclusions. In HFrEF patients, CKD comorbidities associated with worse clinical outcomes. The EMPA-reduced trial enrolled HFrEF patients with a substantial proportion of prevalent CKD and with an eGFR down to 20 milliliter. Empagliflozin improved consistently CV and kidney outcomes in patients with and without prevalent CKD at baseline and across the full spectrum of kidney function down to an eGFR 20. Despite the known acute hemodynamic effects, empagliflozin was not associated with excess risk of investigator-reported acute kidney injury, irrespective of CKD status. And finally, empagliflozin was safe, including in patients with severely impaired kidney function. These results are now published in Circulation, and it is going to be published tomorrow or the day after. And I would like to thank my colleagues at the steering committee and the other oversight committees, as much as the investigator and most importantly, patients who participate in this trial. Thank you so much for your attention.
Thank you, Dr. Zanad. We'll have time just for a few questions and some have come into the Q&A. A number of questions surrounding albuminuria. And one was the renal endpoint less in patients without baseline albuminuria as well?
Well, I wish I could have more time to show you the results as well. We have done the analysis according to the baseline albuminuria, and the results were very consistent across the wide range of albuminuria. So there was no difference in patient with and without albuminuria in this trial.
Thank you. And were the findings in terms of the increases in GFR independent of volume status?
Well, we haven't looked at volume status carefully here because we have no real instrument and careful instrument to look at volume status. But certainly we didn't see any interaction between any side effect related to hypovolemia in patients with and without CKD. And therefore, we don't believe that there is any interaction with volume status and the effect on endpoints across the spectrum of renal function.
Thank you. And would you expect to see similar results in people with heart failure with preserved ejection fraction?
This, I wish you can invite me next year and I will share the result of Emperor Preserved, which is indeed going to be the first heart failure preserved trial with an SGLT2 inhibitor to deliver in a year.
Terrific. And this may be our final question. There was a question regarding the hazard ratios that were presented, and they asked, can you confirm how the hazard ratio was calculated for the renal endpoint? Was it based on a 40% decline in eGFR? And how does this differ from other trials conducted in this area?
Well, it was a small variation according to the guidelines issued by the FDA. There are trials who has set the bar at 50% decline of eGFR. Here we had 40% decline of eGFR, or a decline below 15 if patients started with a low eGFR, plus chronic sustained hemodialysis, plus renal death.
Okay. Thank you, Dr. Zanaat. I think we will end it there and move to our next presenter.
Okay.
So next, we will hear from Dr. Hema Fernandez-Juarez, who is the head of nephrology at the Hospital Foundation de Alcorcón. She will present on sequential treatment with tacrolimus and rituximab versus alternating corticosteroids and cyclophosphamide in primary membranous nephropathy, the STARMAN trial. Dr. Fernandez.
Good morning. Thank you for offering the opportunity to present the study. I don't have any disclosure. This is an independent clinical trial. It has been funded by European Society and Carlos III Institute. Primary membranous nephropathy is one of the most common causes of nephrotic syndrome in adults. Controversy persists about the most effective type of immunosuppressive regimen. In 2012 Kidney Disease Improving Global Outcomes Guidelines for Glomerulonephritis recommended a 6-month cyclical regimen of alternating alkylating agents, usually cyclophosphamide, plus corticosteroids for patients at high risk of progression. Calcineurin inhibitors, both cyclosporine and tacrolimus, have shown efficacy in inducing remission of nephrotic syndrome in about 70% of patients. But the main limitation of these drugs is the high rate of relapse after their discontinuation. An observational study found a reduction in relapse rates when rituximab was administered at the time of tapering of cyclosporine or tacrolimus. We designed a randomized clinical trial to compare cyclical alternating treatment of corticosteroid and cyclophosphamide with a sequential treatment of tacrolimus and rituximab in the induction and maintenance of nephrotic syndrome remission for up to 24 months. One arm received treatment with classical Ponticelli regimen, corticosteroids at months 1, 3, and 5, and cyclophosphamide at months 2, 4, and 6. Other arm received treatment with tacrolimus in monotherapy during 6 months, with tapering off in the following 3 months. At 6 months, a single dose of rituximab was administered to avoid relapses. All patients were followed up to month 24. All potential patients were followed for an observational period for at least 6 months. Inclusion criteria were an estimated GFR over 45 milliliters per minute, persisting nephrotic syndrome with proteinuria over 4 grams per day without a decrease higher than 50% during the observational period, and hypoalbuminemia less than 3.5 grams per deciliters. All patients received the standard of care. Exclusion criteria were secondary causes of membranous nephropathy, previous treatment with corticosteroids 3 months before screening, or other immunosuppressive agents 6 months before screening. The primary outcome was complete or partial remission at 24 months. Secondary outcomes include the rate of complete and partial remission in months between, the number of patients with relapse, the rate of immunological response and the time when it occurred, and the rate of adverse events. 86 patients were randomized in a 1-to-1 ratio to receive corticosteroid cyclophosphamide or tacrolimus rituximab. All patients received study treatment for at least 1 month, and therefore all of them were included in intention to treat analysis. Premature discontinuation occurred in 2 patients in the corticosteroid cyclophosphamide group and in 6 patients in the tacrolimus rituximab group. The remaining patients, 41 in the corticosteroid cyclophosphamide group and 37 in the tacrolimus rituximab group, received the complete intervention. During the follow-up, after the end of the assigned intervention, 5 patients in each group were switched to a non-study intervention because of lack of efficacy of the assigned treatment, and they were considered as no-responder patients. Both relapses and switch patients were considered like no response. And the result, 84% of the patients in the corticosteroid cyclophosphamide group and 58% of the patients in the tacrolimus rituximab group have a primary outcome of the complete or partial remission at 24 months. The difference in the number of patients with complete or partial remission in both groups was already significant at month 3 and was maintained throughout the study. Please look at 12 months. Almost 80% of the patients in the corticosteroid cyclophosphamide had already achieved complete or partial remission, and at 6 months, this percentage was 74. Let's move on to the table below, where only complete remission was analyzed. Most of the patients, 60% in the corticosteroid cyclophosphamide group, achieved complete remission at 24 months. In the tacrolimus rituximab group, 26% of the patients achieved complete remission at this point. And what about immunological response? Anti-PLA2R levels show a significant decrease in both groups. The proportion of anti-PLA2R positive patients who achieved immunological response was significantly higher at 3 and 6 months in the corticosteroid cyclophosphamide group as compared to the tacrolimus rituximab group. From this point, there was no difference between the groups. In the top, you can see Kaplan-Meier analysis. On the left, complete and partial remission, and on the right, complete no partial, complete remission analysis in both groups. The figure below shows the evolution of proteinuria and anti-PLA2R antibodies. On the left graph, in blue, patients treated with corticosteroids and cyclophosphamide, and on the right, those patients treated with tacrolimus and rituximab. There was a close relationship between the evolution of proteinuria and the evolution of anti-PLA2R antibodies. The drop in antibodies was before the drop in proteinuria in both groups, although the drop of proteinuria and antibodies was significantly early in corticosteroid cyclophosphamide group. On the other hand, serum creatinine was significantly lower in the corticosteroid cyclophosphamide group throughout the follow-up. Regarding relapses, one of the patients in the corticosteroid cyclophosphamide group and 3 of the patients in the tacrolimus rituximab group presented a relapse. All of them have achieved only partial remission. Regarding safety, there was no difference in serious adverse events between groups. Overall, any adverse event was more frequent in corticosteroids cyclophosphamide group. More patients in the corticosteroid cyclophosphamide group had leukopenia and Cushing syndrome, while acute kidney injury, hyperkalemia, diarrhea, and distal tremor were more common in the tacrolimus rituximab group. So, in conclusion, treatment with corticosteroids and cyclophosphamide was more effective than sequential treatment with tacrolimus and rituximab in inducing remission. The occurrence of remission was also faster in the corticosteroid cyclophosphamide group, the difference in the number of remission being already significant at 3 months. Most remission were complete in the corticosteroid cyclophosphamide group, while most remission were partial in the tacrolimus rituximab group. Mod regimen induced a significant reduction in anti-PLA2R levels, although immunological response occurred faster in the corticosteroid cyclophosphamide group. Early immunological response was followed by clinical remission in the vast majority of patients, which confirms the usefulness of anti-PLA2R monitoring for a personalized treatment. The number of relapses was low in both groups. This finding supports a beneficial effect of rituximab infused at the onset of tacrolimus tapering to prevent relapses. The rate of adverse effects was significantly higher among patients treated with corticosteroid cyclophosphamide, although there were no differences in the number of serious adverse events. Thank you very much. I will be very happy to answer your question.
Thank you, Dr. Fernandez. We do have a number of questions that have appeared in the Q&A. So we'll jump right in. So one is surrounding the dosing of tacrolimus and the dosing schedule as well. So first was, what was the dose of tacrolimus and what was the target level? And then what was the dosing schedule for rituximab?
The doses of tacrolimus was 0.05 milligram per kilograms to achieve medium levels of between 5 and 7 nanograms per milliliters. So the dose of rituximab was 1 dose of rituximab at the end of the 6th month.
Okay, thank you. And then was the CD19 or CD20 levels documented at any time points following rituximab administration?
Sorry,
I'll repeat, and if we can mute.
Could you repeat?
Yes, could you repeat the question, please?
Sure. So the question was CD19 or CD20 documented at any time points following rituximab administration to indicate adequate depletion after each dose?
So we don't measure the CD19 levels in our patient because the rituximab for us it wasn't a therapeutical treatment. It was a treatment to avoid relapse. So we didn't do this measure.
Okay, thank you. And could you comment on the mentor trial and how does this relate to your study findings and that you just presented?
Sorry, but I can't help you.
The question was whether you could comment on the mentor trial and how this relates to your study results.
Comentar el ensayo mentor comparado con tu estudio.
So the mentor study is a complete different for our study because they aim to compare rituximab in a therapeutical approach. In our case, the rituximab was assessed to avoid the relapse, not from therapeutical point of view. In any case, the number or the result for the cyclosporine in the mentor was very low. The rate of response at 24 months was around 20%. And in our study, the result for tacrolimus, of course, with rituximab, was near 60%. So, of course, the result is very different, but maybe the approach is very different too.
Thank you. And then there was a question about sort of even longer term follow-up and whether the rituximab and tacrolimus patients achieve remission later, sort of beyond what you presented today.
We don't have longer follow-up of the study because we have finished the study right now, so I can give you new results about that. Sorry.
Okay, thank you. Thank you very much. I think we'll end it there. Thanks again, Dr. Fernandez.
Thank you. ¿Qué ha pasado con esto?
Okay, and our next presentation will be by Dr. Glenn Schertow, who is Professor and Chief of Nephrology at Stanford University. And Dr. Schertow will be presenting on global phase 3 clinical trials of vadadustat versus darbepoetin alfa for treatment of anemia in patients with non-dialysis dependent chronic kidney disease. Dr. Schertow.
Thank you very much. It's a pleasure to be here with you. I'd like to thank Dr. Cruz and Dr. Adishu for moderating, Drs. Klein and Fried for inviting us and for leading Kidney Week Reimagined. And I'd also especially like to thank my co-chair, Dr. Kai Yui Eckhart, and the members of our Executive Steering Committee for the Protect and Innovate trials. So I will have the pleasure of presenting the global phase 3 clinical trials of vadadustat versus darbepoetin alfa. I'm of course having some technical difficulties, but here are my disclosures. Funding for this study was provided by Akebia and Otsuka. Briefly, a schema of the study design. These were 2 randomized phase 3 global trials with comparing vadadustat with the darbepoetin alfa active control in patients with non-dialysis dependent chronic kidney disease. There were 2 trials, one in patients who were ESA or erythropoiesis stimulating agent untreated, also known as a correction phase, and ESA treated, another trial with ESA treated patients. So these were patients on active therapy with ESAs who were converted to vadadustat. The target hemoglobin concentrations in the US were 10 to 11 gram per deciliter, and outside of the US, 10 to 12. And one can see the patients were randomized 1-to-1 to vadadustat and darbepoetin. There were several study phases: a screening phase, a correction or conversion phase, or a conversion phase in the ESA treated patients. And to share with you that there was a primary efficacy evaluation phase during weeks 24 through 36, and a secondary evaluation phase of efficacy during weeks 40 to 52. There was, following that, long-term treatment. This was an event-driven trial, as I'll show you in a moment, with safety evaluation over the course of the trial, with a follow-up phase, a short follow-up phase after study discontinuation. The next slide shows the key eligibility criteria. Adult patients with non-dialysis dependent chronic kidney disease. There were no red blood cell transfusions within 8 weeks before randomization. As one can see, for the ESA untreated patients, the baseline hemoglobin concentration was required to be less than 10 gram per deciliter, and there could be There could have been no ESA use within 8 weeks of randomization. For the patients who were treated with ESAs, their baseline hemoglobin concentrations needed to be between 8 and 11 gram per deciliter in the US, 9 and 12 gram per deciliter outside of the US. And we wish to ensure that there was adequate iron stores, demonstrating serum ferritin and transferrin saturation at least 100 nanogram per milliliter and 20% respectively. This was primarily a safety analysis for cardiovascular safety, along with efficacy. Efficacy of vadadustat had been demonstrated in phase 2 trials. The safety analysis was pre-specified as a combined analysis across both the ESA untreated and the ESA treated trials. They were event-driven, and as I mentioned earlier, with respect to the duration of the trial continued until the requisite number of events were collected. We aimed for a non-inferiority margin, the upper bound of which was 1.25. And for the efficacy assessment, the lower bound of the 95% confidence limit was 0.75 gram per deciliter in hemoglobin concentration. And for efficacy, these efficacy analyses were conducted within each trial and much higher power. This slide shows baseline characteristics, which demonstrate excellent balance. Both trials were about 1,750 patients. There were more patients from the US in the ESA untreated trial, fewer patients in the US in the ESA treated trial. And we'll proceed with the primary findings. This slide shows the primary endpoint, MACE, defined here as all-cause mortality or non-fatal MI and stroke. Expanded MACE, which included thromboembolic disease and hospitalized heart failure. And then all-cause mortality, cardiovascular MACE, and cardiovascular mortality. And if we focus on the top row of MACE, which was the primary endpoint, we can see that the vadadustat versus darbepoetin comparison did not meet the non-inferiority margin of 1.25, with the confidence limits extending beyond that range. Now, I would point out here the model that was designed to come up with the hazard ratio included age as a dichotomous variable, less than or equal to 65 versus greater than 65. That is valuable for presentation purposes, but does not yield the most precise treatment estimate because, of course, adjusting for a 63-year-old versus a 33-year-old, there are very different risks of death or cardiovascular disease. So this slide demonstrates basically analyses repeated using age as a continuous variable in the Cox model. Again, though, the hazard ratios were attenuated. The 95% confidence limit did not meet the non-inferiority criterion. Here we see results from a pre-specified subgroup analysis comparing those patients, again, pooled across both trials. When, as I mentioned earlier, there were more patients in the non-ESA treated trial were from the US, and fewer patients in the US in the ESA treated trial, but pooling patients in the US versus patients outside of the US, we can see that the curves for patients in the US whose target hemoglobin concentration was 10 to 11 gram per deciliter had roughly similar hazards. This is for the primary endpoint MACE, whereas the patients outside of the US who had a target hemoglobin of 10 to 12 rather than 10 to 11 experienced an excess of MACE events in the vadadustat treated patients. And this slide shows again the hazard ratio and 95% confidence limits for MACE in US and non-US patients, as well as the other endpoints, expanded MACE, all-cause mortality, etc. This slide shows on the left panel the ESA untreated patients, and in the right panel the ESA treated patients. That is the two different trials based on pre-trial participation ESA use. And so in the trial comparing vadadustat and darbepoetin in patients who are ESA untreated, we can see the curves are roughly parallel. And similarly, in the patients who were ESA treated, though their baseline hemoglobin was a bit higher than the baseline hemoglobin for patients in the ESA untreated trial, the curves were parallel, and the numbers in the boxes below show minuscule differences between vadadustat and darbepoetin. And in terms of efficacy for both trials, vadadustat met its non-inferiority target. There were a number of treatment-emergent adverse events. Apologies for the small size of the slide, but we wanted to show all treatment-emergent adverse events that occurred in 10% or more of patients in one or both groups. And those treatment-emergent adverse events were similarly balanced across the two groups. So to conclude, with respect to cardiovascular safety, vadadustat did not meet pre-specified non-inferiority criterion compared to darbepoetin alpha with respect to cardiovascular safety in patients with anemia and non-dialysis dependent chronic kidney disease. And many of you probably saw Dr. Eckhart's presentation from the INNOVATE trials, which demonstrated that vadadustat did meet the pre-specified non-inferiority criterion in those two trials. Using age as a continuous variable, the hazard ratio and upper bound of the confidence intervals were attenuated. And as we saw, the cardiovascular risk was similar between the two treatment arms in the US, where the hemoglobin target was 10 to 11 gram per deciliter, but was higher in patients randomized to vadadustat in the regions using a higher hemoglobin target of 10 to 12. In terms of efficacy, vadadustat was non-inferior to darbepoetin in maintaining target range hemoglobin concentrations during both the primary and secondary evaluation periods. Thank you very much for your time and attention.
Thank you, Dr. Chertow. There are a number of questions that have come in. One was regarding the difference in the inclusion criteria, or the targets rather, for hemoglobin in the US compared to outside of the US. And so wondering, why was that target hemoglobin different or less in the US than the target hemoglobin outside of the US? And then a similar question around some of the other eligibility criteria that differed by country.
Well, we aimed in the trial to follow prevailing clinical practice guideline target-based ranges for the hemoglobin concentration. So as you know, in the United States, the FDA label suggests for ESAs that the lowest dose of ESAs to abrogate the need for blood transfusion should be the chosen dose, and the clinical practice guideline targets suggest 10 to 11 gram per deciliter. And in the EU, and I guess what remains of the EU and rest of Europe and other areas of the world, the targets are in the 10 to 12 gram per deciliter range. So it was simply to maintain, it obviously added complexity to the trial, but it was to maintain region-specific guideline-driven targets.
Thanks. And so one question highlighted the statistically significant safety signal in the vadadustat arm, and so that obviously a major concern is safety. They went on to ask, what was the achieved hemoglobin in the US versus the non-US?
So the achieved hemoglobin concentrations were lower. We just received these data just 3 or 4 weeks ago. So we're still conducting analyses of a number of issues, trying to better understand the findings. And we are working to expeditiously publish these main results. But I can't really speak to more than that now, because we're really just digging into the complexity of the analyses on some of those areas, like achieved hemoglobin.
Great. And so I think surrounding that, there was a question around individual differences between the hemoglobin levels of variability between ESA and vadadustat, but presumably that's also work to come since you all are conducting those analyses. There was a question around the target as far as ferritin, and wondering if you could comment on the threshold of ferritin of 100, which is lower than the 2012 KDIGO threshold of 500 for adequate iron stores.
I'm not quite sure how to respond to that. Certainly, there are many patients, as you know, with high ferritins who have chronic kidney disease. But I believe that the ferritin concentrations that you're referring to are referring to patients who have chronic kidney disease on dialysis, as opposed to the patients who have non-dialysis dependent chronic kidney disease. So we wanted to ensure that patients were not being treated with either agent in the setting of iron deficiency. And so we ensured before enrollment that patients had at least a serum ferritin of 100 and a transferrin saturation of 20% or higher, and encouraged the use of iron in both groups to maintain those levels, again, to ensure that we weren't using more of either agent than we needed to hit hemoglobin targets.
Great, thank you. We'll have to end it there. Thank you, Dr. Schertau. So next, I'll turn things over to Dr. Ardishu, who will introduce our next speakers.
Thank you, Dr. Cruz. It's my pleasure to introduce Dr. Daniel Weiner, who's an associate professor from Tufts University and associate medical director of Dialysis Clinic. And he'll be speaking about oral intradialytic nutrition supplements and mortality in hemodialysis patients, results from a cluster randomized pragmatic clinical trial.
All right, thank you so much. And good day, everybody. Hard to know exactly where people are, so go with the neutral good day. I just want to thank ASN for this opportunity to participate in this really outstanding session, and just congratulate in advance on the Kidney Week Reimagined effort that's gone into this. It's impressive. That stated, it'll be wonderful to hopefully get together in San Diego next year and see old friends and make new friends and collaborators. So what I'm presenting today is the results of our cluster randomized pragmatic clinical trial that looks at a very real world question that we're facing in dialysis patients. Do nutritional supplements help? And in particular, do they help in people with reasonably intact nutritional status, measured albeit imperfectly by serum albumin levels? So these are my disclosures, which can also be seen on the website. The most important disclosure here in red is for a large pragmatic trial that really just finished. There's a lot of data cleaning that's going into this. So this is really a very early preview of what our results show, but there are a lot of questions that we haven't yet answered. So as noted, this is the HELPS HD trial, and this is flying through very quickly. This is the HELPS HD trial, Health Effects of Oral Protein Supplements in Hemodialysis. Our hypothesis here was that giving nutritional supplements to all patients, regardless of their albumin level, so that's our intensive protocol, would result in lower mortality over a 3-year period when compared to patients on the current standard of care nutritional supplement protocol. In the dialysis facilities in the United States, that largely means giving oral nutritional supplements to people with lower serum albumin levels, less than 3.5. When we launched this trial, there were reasonable observational data based upon natural experiments that people with low serum albumin levels benefited from nutritional supplements. And as a pragmatic trial, we really needed a whole lot of buy-in from all of the medical directors and dietitians across the DCI facilities that participated. And none of us were really willing to stop nutritional supplements in people with low serum albumin levels. We all believe strongly that that helped. So we are really asking the question, is nutritional supplements in everybody versus nutritional supplements in people with low serum albumins? These are the protocols. And you can see this here. I apologize for this. I'm just having some technical difficulties. What we did, we tried to keep this as real world and pragmatic as possible. So we used standard nutritional supplements. You can see about half the people used protein bars, with the criteria being that we wanted about 15 grams of protein in every supplement that we're using. So everything had about 15 to 20 grams of protein. And we did this because we wanted to keep this real world. We wanted this to be scalable. Depending on the results of the trial, we wanted this to be something that could be adopted by dialysis facilities across the US and worldwide, at least in those facilities where they don't provide meals to patients. Our study design was a cluster randomized trial by facility. We randomized facilities in late 2016, and we consented prevalent patients in late 2016 into early 2017, and began the trial in late January 2017. Because we were randomizing facilities, when facilities had new patients start, they were rolled into the trial. They were consented at the time of dialysis initiation. This makes things a little bit confusing in as much as every patient within the DCI nutritional supplement trial receives supplements for the first 120 days. So we can't get any separation in our supplements for about the first 3.5 to 4 months. We ended consenting people in January 2020. We were planning on going a little bit longer for follow-up. Unfortunately, this thing called COVID got in our way. And with masks and concerns over food and eating in dialysis units, we ended up terminating the trial in terms of the intervention in March. So here are our results. We randomized 10,457 hemodialysis patients from 105 participating facilities. Because of this early separation issue and incident patients moving to other places or unfortunately dying, about 400 of those patients were excluded from primary analyses. This was a very generalizable dialysis population. Mean age was 63 years, a little bit more men than women, about a third Black, 45 to 50% diabetes as primary cause. There were some mild imbalances between the groups, but nothing marked. Median follow-up was a little bit under 2 years. And critically, we were able to get separation between the groups. There were about twice as many supplements consumed in the intensive facilities rather than in the usual care facilities. So we got separation with this protocol. And I think the most important thing about how we got separation, and the most important thing to remember here, is this was done in a very pragmatic fashion. We did not have research coordinators doing this. We had study champions. And the study champions were the dietitians largely at each unit. In some places, it was the nurse managers. And these were the people who did the consent. We had a waiver of consent documentation, and we had a short form for consent, given that this was a minimal risk protocol. So a lot of elements in here made this a very pragmatic study design and hopefully scalable to the real world. Unfortunately, these are our results. The hazard ratio is essentially right at 1, with confidence intervals that very readily span that 1.00 hazard ratio. And you can see, unfortunately, as is too often in dialysis trials, we end up with Kaplan-Meier plots that look like this, where your 2 lines actually unfortunately look like 1 line. These were done in 2 different ways. They were done with the lagged analysis to account for the fact that there's no separation over the first several months for incident patients, and then done from time 0 regardless of what is occurring with dialysis patients. And again, unfortunately, these are relatively overlapping lines. So in conclusion, what we found was that there's no difference in mortality outcomes between an intensive and standard oral nutritional supplement protocol. I think it's really, really important to say that this doesn't tell us anything about giving protein supplements to people with low serum albumin. It says nothing. We have reasonable observational data that suggests that that is a good thing. We have good basic science data that shows that hemodialysis is a very catabolic procedure and that oral nutritional supplements can abrogate some of this catabolism. So this does not speak to people with low serum albumin. It only speaks to people with more normal serum albumin levels. We do have ongoing analyses looking to see what happens to serum albumin levels in these two groups, separating out incident versus prevalent patients and other things like that that we have not yet completed. And we also have a great deal of data on hospitalization, which we have not yet completed, but focused rather for this presentation on the primary all-cause mortality outcome. I think the other really key conclusion here is that we were actually able to consent and randomize more than 10,000 hemodialysis patients. For those who started in at the beginning, we have more than 3 years of follow-up on those patients, a time sufficient to really look at mortality and other outcomes that are easily measurable like that. A limitation is we didn't measure patient-reported outcomes, unfortunately, because we relied entirely on systems that are in place. I think it's a key conclusion that we were able to achieve separation, and this was through engagement, both with the patients and with the staff, particularly the dietitians who really believed in this trial and really were fully invested in this trial. And I think it shows what can be done with a relatively low resource design. The major costs behind this trial were the nutritional supplements themselves. But beyond that, this was scalable across more than 100 dialysis units. So in conclusion, I think there's a lot of thanks here for this trial that was entirely sponsored by DCI. I don't know if we can go back a slide or two on this. But I think we have to thank our dietitians and our nurse managers, the medical directors who took a plunge and decided to engage in a clinical trial. I think the spirit at DCI of engagement, this was fully funded internally. And then everybody who worked on the trial. We had a DSMB and statisticians, and it was a team effort. And I think as we came to the close, we really have to thank the patients who participated and all the staff who participated, especially through such trying times that we've seen in dialysis and actually in the whole community in 2020. So thank you very much.
Thank you so much, Dr. Weiner. Excuse me. Can you comment about a couple of things related to the interventions? So the adherence to using the oral nutrition supplement and whether you measured the patient's protein intake at baseline and over the course of the study outside of what we were supplementing with.
We did not measure what was going on externally. Ultimately, if you believe in NPCRs, we'll be able to look at that through KT over Vs and get some idea of overall protein intake that's going on in that setting. The adherence was reasonable. The way that we can measure that very crudely is looking at actually what each individual facility ordered in terms of nutritional supplements and we're handing out. So we know what the utilization of supplements were. There is a field that every patient had to, for every patient that was entered with regard to actual consumption. And the consumption overall was good. I would say we had probably about 90% adherence to this. There were people in facilities who did not take supplements, people who refused, and most DCI facilities also allowed most of the time up until COVID people to eat. So there were other sources of intake that were occurring there. I don't think that's all that important because really the purpose of this was to test whether a universal protocol like this would make an impact on a mortality outcome. So making this as real world and pragmatic as possible was the key.
Terrific. Another question for you in the chat was, what was the socioeconomic status of these patients and how many of them fell into the low economic status group?
So we actually don't have great data on that. What I can tell you is it was a nationally representative population of dialysis patients in the United States. So it was 105 units, and there was 90 to 95%, and some even at 100% consent rates for participation in the study among the patients dialyzing at those units. So it's really consistent with what we're seeing in terms of the hemodialysis population that we take care of.
And then can you comment about the measurement of serum albumin and the change in albumin over time between the groups, and whether you did any sub-analysis for a low baseline albumin versus normal baseline?
Yeah, I think where we really need to look at is that group with albumins in that 3.6, 3.7 range. Based on the protocols, everybody below 3.5 is going to get supplements every month, no matter what, regardless of which group you are randomized to, which group your facility is randomized to. If you invite me back next year, I'll present that.
And can you comment about hospitalization data? Was there a difference in the rate of hospitalization between the groups?
As of right now, we've looked at time to first hospitalization, which is much easier to look at. Obviously, hospitalization is an exceptionally complicated variable, and using clinical data from clinical EHRs that requires a lot of cleaning and reconciling, which is still a work in progress. The time to first hospitalization, there was no significant difference on this first look between the two groups.
Terrific. Another question that was posed was, were there any differences in the rates of intradialytic hypotension?
We did not see that. Again, for those who work in dialysis facilities, that's something that is captured in real time, and as a pragmatic trial, that's not always perfectly documented. We have not yet gone through the individual blood pressure readings and looked at a more careful, adjudicated way to measure that.
And a question regarding the fixed dose of the supplement of 15 grams to 20 grams of protein, which on a milligram per or a gram per kilogram basis would be different for patients of different body size. Can you comment about that?
So what we ended up choosing, again, to keep this as pragmatic as possible, was what's going on in real practice. So it was a single serving size of Prostat or of a nutritional supplement or of Liquicell. So just based strictly on what the recommended serving size was for that. Honestly, I couldn't really necessarily see these being portioned to individual patients based upon a per body weight once you try to implement something like this in a real world setting to hundreds of thousands of dialysis patients. So we kept this as pragmatic and practical as possible so that hopefully it would be scalable.
Thank you so much, Dr. Weiner. I think that's the end of our Q&A portion.
Great, thank you so much.
For your presentation. Next, I'd like to introduce Dr. Martin Gallagher, who's the Director of Renal and Metabolic Division in the George Institute, an Associate Professor at the University of New South Wales in Sydney, and he will be presenting about the reduction trial.
Okay, thanks very much. And thanks for the opportunity to present the results of the reduction trial on behalf of the reduction investigators. We haven't got any substantial disclosures of note here. I'd like to start off by thanking the large number of partners and sites that participated in this trial, which were represented from all the states and territories of Australia. And there were literally hundreds of people who sat behind the study who've done a lot of work on it. Global healthcare-associated infections are a global health issue and complicate between 10 and 15% of hospitalisations. And central venous catheters are an important driver of this through central venous catheter-related bacteremia, which is estimated to cost up to $45,000 US per episode. In nephrology, this is played out in the form of hemodialysis catheter-related bloodstream infection. Hemodialysis catheter exposure is ubiquitous in global nephrology. The estimated catheter-related bloodstream infection rates vary in reports from between 1.1 to 5.5 per thousand catheter days. And catheter usage is an independent predictor of mortality in dialysis populations, such that there's been a number of initiatives in the last 10 to 15 years to reduce exposure to catheters and enhance fistula usage. At the start of this study, we did a survey of 48 renal services from Australia and New Zealand. And the key finding out of that survey was that the variation in practice around catheter care. So variations in the skin preparations used at insertion, in the locking solutions used in managing catheters, and the catheter dressings that are used to prevent exit site infections. In addition, the reporting of catheter-related bloodstream infection rates was done mostly by sites, but only around half of those collected that data prospectively, and only around half could provide a value to the surveyors that we understood. In addition, only a third of units could compare, and most of those units could compare to other services, and most of that was done in New Zealand alone. So this project set out to systematically measure the use of hemodialysis central venous catheters at the national level in Australia. It then sought to accurately determine the rate of catheter-related bloodstream infections and to test the effect of a multifaceted evidence-based intervention upon the rate of catheter-related bloodstream infection using a cluster randomised design. The design paper was published in Kidney 360 earlier this year and has more detail, and I'd encourage people to search that up. The study operated in 37 renal services across Australia, and during the study, all incident hemodialysis catheter insertions were eligible for data collection. Data was collected from the time of insertion to the time of removal and entered into a purpose-built web interface, which allowed real-time reporting at the site level. Data was collected around the nature of catheters inserted and the nature of the patients receiving those catheters. The consent model was an opt-out or a waiver of consent model, which varied by jurisdictions. The baseline phase of the study was purely observational, although it did allow many sites for the first time to be able to look at real-time bacteremia rates in their service, and it ran for a minimum of 12 months. The intervention phase employed the evidence-based intervention in 3 tranches at over 6-month intervals. And in this phase of the study, the sites could compare their own rates of bacteremia with the project-wide catheter-related bacteremia rate. Sorry, there's a bit of a lag here. The intervention package had a number of elements to it, and they were broadly packaged into 3 time points in the phase of catheter use. There were interventions focused around the insertion point, there were interventions focused around the maintenance phase of catheters, and also around removal. More detail around this is available in the design paper. The primary outcome was confirmed hemodialysis catheter-related bloodstream infection, which required clinical suspicion of infection, along with a positive tip culture or with a positive blood culture, or more than two or more blood cultures, or bloodstream infection in the absence of another source. There were 3 secondary outcomes. The first of those was suspected or possible catheter-related bloodstream infection, and that was mainly around patients who had catheter removal for suspected infection and did not meet the primary outcome definition. Another of the secondary outcomes was confirmed or suspected, and that was a combination of those 2 definitions I've outlined above. And then there was an outcome of total hemodialysis catheter-related infection, which included where sites had reported exit or tunnel infections. Blinding wasn't possible in the study, but the nature of the intervention was kept confidential during the baseline phase until the sites were ready to enter the intervention phase. There was independent adjudication of all events. The powering was based on a catheter-related bloodstream infection rate of 2.5 per 1,000 catheter days, which gave us a 90% power to detect a 50% reduction. The primary analysis was done using a generalised linear model, and that was unadjusted except for the period effect of time. This chart illustrates the study flow, and in the light blue is the baseline phase, and the dark blue, the intervention phase. And you can see a good balance in the total catheter exposure across the 3 tranches, which ran between December of 2016 and March of this year. The patient characteristics of the more than 6,000 patients who contributed data to the study is seen here, with around 60% being males and an average age of 61 full stop. There was a higher representation of First Nations people, which probably reflects the burden of kidney disease in that population. Of note was that over 40% of patients had diabetes and around 13% of patients were on immunosuppressants as well. The catheter characteristics are best summarised by the fact that the vast majority of catheters were tunnelled catheters. They were inserted in the right side of the body into the internal jugular vein. The reasons for catheter insertion were primarily acute kidney injury or the start of maintenance dialysis. Fewer numbers of catheters were inserted for transfers from peritoneal dialysis or fistula or graft thrombosis. The primary outcomes presented here, again, is catheter-related bloodstream infection. And you can see that in the baseline phase, the rate of the primary intervention was 0.31 per 1,000 catheter days, which was substantially less than the values we had powered the study on. That fell to 0.24 during the intervention phase. The estimated effect size of the intervention is summarised in the rate ratio, which came out at 1.3 with a broad confidence interval and a p-value of 0.31. The secondary outcomes similarly didn't show any statistically significant effects from the packaged intervention, again with broad confidence intervals. We had two pre-specified subgroup analyses, which were based on the size of the services at enrolment and the requirement for changes in dressing or catheter locking solutions during the intervention phase. Neither of these subgroup analyses suggested there was an interaction between the study intervention and the primary outcome on these bases. So the strength of the study is it's a large study which is generalisable to patient populations, probably in developed countries. It was a pragmatic suite of interventions which was taken up fairly readily by sites. It used a randomised design, which has been lacking in many of the studies in this space. It also had endpoint adjudication and included acute kidney injury patients who are a large proportion of the patients coming through services. The study was limited by the lower than expected event rate, the probable Hawthorne effect at play. And we weren't able to measure the extent of capture of services. So if services didn't insert all of their catheters, we weren't aware of that. There was an inability to blind the services as well. So our evidence-based multifaceted package of interventions did not impact upon the rate of the primary or any of the secondary outcomes. One of the key issues that we've been exploring is the fact that the rate of the primary outcome did fall into the intervention, yet the point estimate for the intervention effect was over 1, was 1.3. We think this is two likely reasons. Most likely is the much lower primary event rate that we saw. And that means that there's a much higher risk that there's a play of chance here. And we think there's a fair degree of, or a large degree of imprecision around that 1.3 estimate. In addition, there are a lot of other factors that are influence the primary outcome here that may be at play during the totality of the project, which aren't captured within the intervention phase. And it may be that those factors are driving a lot of the change. So the implications of the study is that the burden of catheter-related bloodstream infection in Australia appears low, but it should be borne in mind that on average, of 10 patients having a catheter for a year, on average, one of those will have a catheter-related bloodstream infection. And this has implications for jurisdictions where you have high exposure to catheters. Cluster randomisation is an important tool to be used here to understand treatment effects, and future studies here will be challenging because of the low event rates and the fact that multifaceted interventions or bundles on complex systems may require large numbers of components in those bundles, which are then by definition harder to implement. Again, I'd like to finish by thanking the partners and sites, and especially the members of the adjudication committee who worked tirelessly on the study, as well as Sarah Coggan, Kate Higgins, and the staff at the George Institute. Thanks.
Thank you very much, Dr. Gallagher, for that wonderful presentation. There is a question from the audience about whether there was any difference in the KT over V noted.
We didn't measure clearance as part of the study. It's like Dan's trial. It's a pragmatic study which sought to minimise the impact upon sites and the burden of data collection.
Thank you. And then can you comment about the low event rate that you found? And it was quite different than what you had hypothesized at the baseline. Factors?
Look, I think part of that was likely history. My suspicion is that catheter-related bloodstream infection rates have dropped quite dramatically in recent years. When we designed the study in 2015, we thought 2.5 was a reasonable estimate, and we had data in Australia which suggested it was a reasonable estimate. But it's been shown that it was vastly overestimated the rate. But I'd reiterate the fact that even 0.31 sounds like a low number. But in fact, when you transform it into large numbers of dialysis patients with catheters, you start getting some big numbers.
And if I can ask one last question, any follow-up implementation studies to assess aspects of the bundle that were more successful than others?
Yes, we've used data linkage to administrative data sets and the ANZ data registry in Australia. And so we've got a large swathe of data coming, which will allow us to look at a variety of factors that may well influence outcome going forward.
Wonderful. Thank you so much, Dr. Gallagher. That ends our Q&A session. And we'll move on to our next speaker, Dr. Alexander Zarbach, who's a professor from the University of Munster. And he will be speaking about the effect of regional citrate anticoagulation versus systemic heparinization during CRRT, a focus on filter lifespan and mortality results from a randomized clinical trial.
Thank you very much. First of all, I would like to thank the organizers for giving us the chance to present our data here. I'm presenting on behalf of the RICH investigators. Here you see my disclosures. So acute kidney injury is a common complication in critically ill patients. Approximately 50% of all ICU patients develop an acute kidney injury, and some patients require renal replacement therapy. Normally, critically ill patients receiving continuous renal replacement therapy also get anticoagulants to reduce filter clotting and prolong filter lifetime. Filter clotting is associated with a couple of problems like inadequate therapy. A premature or frequent filter change goes along with a downtime. During this time, the patient doesn't get any therapy. In addition, if the filter clots, then you can not retransfuse the blood that is in the extracorporeal system. The workload is higher if the filter clots, and the costs also increase. During filter clotting, you have a high transmembrane pressure, and this triggers alarm that produces a lot of noise and distractions. Therefore, filter clotting should be avoided. As the blood gets in contact with the extracorporeal surface of the CRRT, the coagulation system gets activated. Here on the left side, you see the coagulation system, and you see that calcium is required in many steps of the system. If you eliminate calcium by adding citrate to the blood, then you can effectively inhibit the coagulation system as citrate binds calcium. Here on the right side, you see the setting of a regional citrate anticoagulation system. Citrate is added to the blood of the patient once it leaves the body. To be effective, the ionized calcium should be between 0.25 and 0.35 millimole per liter. Most of the citrate calcium complexes are removed during the extracorporeal circulation. Before the blood enters the body, calcium is added to the blood. This is a landmark study which was performed by Helen Outermans. It is a single center study, and the authors recruited 215 patients. Here, the authors investigated heparin against regional citrate anticoagulation. Also, they couldn't show a prolonged filter life in the regional citrate anticoagulation group, which was shown in many previous studies. They demonstrated that surgical patients receiving regional citrate anticoagulation had a better outcome. In contrast, they didn't see a mortality difference in medical patients. This is a Cochrane meta-analysis which was published this year. Here, the authors demonstrated that major bleeding, treatment cessation due to adverse events, and thrombocytopenia was significantly reduced in patients who get regional citrate anticoagulation. However, they couldn't demonstrate that regional citrate anticoagulation prolonged filter life compared to heparin. In 2012, the KDIGO guidelines recommended to use anticoagulation during renal replacement therapy if the patient doesn't have an increased bleeding risk or impaired coagulation and is not already receiving systemic anticoagulation. This is a 1B recommendation, so the evidence is quite good for this recommendation. In addition, the authors suggested using regional citrate anticoagulation rather than heparin in patients who don't have contraindication for citrate. Based on the literature, this was a 2B recommendation. Based on the weak recommendation, we planned and performed the RICH trial, which was recently accepted for publication in JAMA. We started with the recruitment in March 2016 and finished the recruitment in December 2018. Our hypothesis was that regional citrate anticoagulation for CRRT increases filter life and decreases mortality in critically ill patients with acute kidney injury as compared to the use of systemic heparin anticoagulation for CRRT. We had a co-primary outcome. This was filter life and overall survival in a 90-day follow-up period. Based on our calculation, we had to recruit 1,260 patients. An interim analysis was performed and the study was stopped early. Here you see secondary endpoints. We looked for length of ICU stay and length of hospitalization, duration of renal replacement therapy, recovery of renal function by day 28, bleeding complication, transfusion requirements, rate of infection. And here you see the study flows. So we wanted to only recruit critically ill patient with an acute kidney injury, and the patient had to fulfill an absolute indication for CRRT or a severe AKI and at least one of the following conditions: severe sepsis, use of catecholamines, refractory fluid overload, or the development of progression of non-renal organ dysfunction. And then the patients were randomized either in the regional citrate group. Here, the target of the ionized calcium was 0.25 to 0.35 millimole per liter. And in the systemic heparin group, the target PTT was 45 to 60 seconds. And here you see that we screened more than 5,000 patients. 4,400 patients had to be excluded because they met the exclusion criteria. So 638 patients were randomized, 319 into the regional citrate anticoagulation group and 319 patients into the systemic heparin anticoagulation group. We were able to analyze 300 patients in the regional citrate anticoagulation group and 296 in the systemic heparin anticoagulation group. Here you see the demographic and the baseline characteristics of all patients. There were no differences regarding demographics and baseline characteristics. Here you see the co-primary outcome. There was a significant difference regarding the filter life. The filter life was significantly longer in the regional citrate anticoagulation group compared to the heparin group, as you can see on the left side, but there was no difference in the mortality between both groups. We also looked for other secondary outcomes, and here we also demonstrated that the bleeding rate was significantly higher in the systemic heparin anticoagulation group compared to the regional citrate anticoagulation group, 70% versus 5.1%. But surprisingly, we also demonstrated that the infection rate was significantly higher in the patient who received regional citrate anticoagulation compared to systemic heparin anticoagulation, 68% versus 55%, as you can see here. Here you see the adverse events. Patient of the regional citrate anticoagulation group more frequently developed severe alkalosis and hypophosphatemia. Hyperkalemia was more frequent in the heparin group. Gastrointestinal complications were lower in the regional citrate group as compared to the systemic heparin anticoagulation group. All other adverse events didn't differ between the two groups. And here are the conclusions. Use of regional citrate anticoagulation resulted in significantly longer dialysis filter lifespan. Regional citrate anticoagulation had no effect on the mortality rate of critically ill patients with acute kidney injury compared to the systemic heparin anticoagulation group. This was true for the 90-day mortality as well as the 1-year mortality. There were less bleeding complications in the regional citrate anticoagulation group, more adverse events in terms of metabolic complication, and a significantly higher infection rate were seen in the regional citrate anticoagulation group. Last but not least, I want to thank all our collaborators and, of course, the patients who participated in this trial. Thank you very much for your attention.
Thank you very much, Dr. Zarbach. There is a question in the chat related to the type of citrate solution that was used and whether that was the same at all sites.
No, it was not the same at all sites because the sites used different machines, and that's the reason why they used also different solutions. But only centers who had an established regional citrate anticoagulation protocol were able to participate in this trial.
And can you comment about the achieved dialysis dose that was delivered and whether that was comparable between the groups?
It was comparable between both groups, and it was higher than 25 milliliter per kilogram per hour. Yes.
Thank you very much. Another question that came in was related to costs. Were you able to do an assessment of the cost of using citrate solution versus heparinization?
This is a really good question, and this is one of our secondary endpoints, but we haven't analyzed this yet, but we will definitely do this because in the regional citrate anticoagulation group, the filter life was significantly longer and also the downtime. So it suggests that it has an impact on costs, but we haven't analyzed this yet, but we will.
Terrific. A question about the study termination. Why was the study terminated early?
So after 400 patients, we had an interim analysis, and during the interim analysis, we still recruited patients. And then after or during the interim analysis, we saw that the primary outcome was significant. So the filter life was significantly longer in the regional citrate anticoagulation, but there was no difference in the mortality. So whatever. So, and we in the protocol, we predetermined that we were able to increase the number of recruited patients up to 1,400 patients, but not higher. And in the interim analysis, it said that we had to recruit more than 3,300 patients to get a significant regarding the mortality. That's the reason why we terminated early.
I don't know if we have time for one more question, but the signal on the infection rate with citrate is a little surprising. Can you comment more about that and whether you have data on the subtypes of infections, et cetera?
So it was also surprising for us, to be honest with you, and we looked for the bacteria and the source. There was no difference regarding the source of infection. So that means pneumonia or catheter-related infection, but there was a difference regarding the bacteria. So in the regional citrate anticoagulation group, more patients had a gram-positive infection. So, but we have to investigate this in more detail, but we have the data, but haven't analyzed it yet. So.
Thank you very much, Dr. Zarbach. That ends our question and answer period. And it's my pleasure to wrap up the session and introduce Dr. David Wheeler, Professor of Kidney Medicine at the University College London, who will be speaking about the results of the DAPA-CKD trial.
Well, thank you very much for the opportunity to present these data from the DAPA-CKD study, and I do that on behalf of my collaborators who are listed here. I may have to ask the technicians to advance. Nope. I'm okay. Thank you. I'm okay. Thank you. So here are my disclosures. So SGLT2 inhibitors, as we all know, were developed as drugs to improve glycemic control in patients with type 2 diabetes. In the CREDENCE study, canagliflozin improved both cardiovascular and kidney outcomes in patients who had the combination of type 2 diabetes and chronic kidney disease. We did not know whether these benefits extended to patients who had chronic kidney disease, but who did not have type 2 diabetes. And the DAPA-CKD study assessed the clinical outcome benefits of dapagliflozin in patients who had chronic kidney disease, but due to a broader range of underlying etiologies, not just diabetic kidney disease. So this is a pre-specified secondary analysis of the DAPA-CKD study in which we examine the effects of dapagliflozin on the primary and secondary outcomes according to the underlying cause of kidney disease. Now, our primary outcome in this study was the composite of a greater than or equal to 50% decline in eGFR, and that needed to be confirmed with a follow-up blood sample. The development of end-stage kidney disease, that's an eGFR of persistently greater than 15, or the need for dialysis or kidney transplantation, and death due to either renal or cardiovascular causes. Our secondary outcomes were the composite of a 50% decline in eGFR with end-stage kidney disease and renal death. So that's the primary outcome without the cardiovascular death component. So this is a pure renal composite. Our second secondary endpoint was a cardiovascular composite of cardiovascular death and hospitalization for heart failure. And our third secondary outcome was all-cause mortality. So here's our study design. We recruited adult patients with eGFRs between 25 and 75 mils per minute and urinary albumin to creatinine ratios between 200 and 5,000 milligram per gram. Now, because ACEs and ARBs are standard of care in this patient population, proteinuric CKD, we required patients to be on the maximum tolerated dose of ACE or ARB going into this study, if at all possible. Now, it didn't matter what the cause of chronic kidney disease was, except that we excluded patients with type 1 diabetes. We excluded patients with polycystic kidney disease, and we excluded patients with immune-mediated systemic or glomerular disease that was felt to require immunosuppressive therapy. In the trial, we randomized patients 1-to-1 to dapagliflozin 10 milligrams or to match placebo in a blinded manner. We followed the patients until just after a DSMB meeting that recommended stopping the trial prematurely. We were told due to overwhelming efficacy, and the median follow-up of these patients turned out to be 2.4 years. So we recruited 4,304 participants from 386 sites in 21 different countries, including the US. All those countries are marked in blue on this map. Now, of those participants, 2,906, so 2/3, had type 2 diabetes as a comorbidity, and so 1/3, 1,398, did not have type 2 diabetes as a comorbidity at baseline. Now, first, let's look at the outcomes by diabetes status. And we've already presented and published these data showing the beneficial effects of dapagliflozin on the primary outcome at the top here and on all three of the secondary outcomes. We've also shown that for the primary outcome, there was a consistent effect in those who entered the trial with and without a diagnosis of type 2 diabetes. And we're now showing that this was also the case for the secondary outcomes. So you see here the secondary outcomes added in by diabetes status. For example, looking at the all-cause mortality outcome at the bottom here, you can see that the reductions in risk were nominally statistically significant, whether or not the patient had type 2 diabetes at baseline. So let's move on to looking at these data by investigator-reported cause of chronic kidney disease. And let me stress that this is what the investigator wrote on the case report form as the cause of chronic kidney disease in the patient that had been recruited into the study. In about 20% of these patients, the diagnosis was supported by kidney biopsy. So you're looking here at the trial population by diabetes status. Remember, 2/3 had type 2 diabetes at baseline. If we look at causes of kidney disease, investigator-reported causes of chronic kidney disease, only 58.3% of patients were thought to have diabetic nephropathy as their cause of chronic kidney disease. Why is that? Moving over to the right, we see that of those with type 2 diabetes, 14% had causes of kidney disease other than diabetic nephropathy. So not all the diabetics were thought to have diabetic kidney disease. The causes other than diabetic nephropathy in this trial were the glomerulonephritidis, ischemic or hypertensive nephropathy, and kidney disease, chronic kidney disease due to other or unknown causes. So here we see the baseline characteristics by underlying cause of chronic kidney disease across the top here, then subdivided by treatment allocation in the study. So the patients with diabetic nephropathy and ischemic nephropathy tended to be older and tended to be heavier than the patients with the glomerulonephritidis and chronic kidney disease of other or unknown cause. Those groups with non-diabetic kidney disease tended to have lower GFRs and lower levels of albuminuria, and the patients with glomerulonephritis tended to have lower blood pressures, or perhaps this is better treated hypertension than those in the other groups. Importantly, there's a good balance here between those patients randomized to dapagliflozin or placebo within all these different etiological groupings. So here's our primary outcome according to the underlying cause of chronic kidney disease. This is the overall result at the top that you've already seen. Here is the primary outcome divided by disease etiology, and you can see here a consistent effect. Here's the P for interaction, which is not statistically significant. These results are very similar, as you can see. And we're going to now show the first secondary outcome. Remember, that's the primary without cardiovascular death. So things hardly change here. Again, a consistent effect regardless of the underlying disease etiology. So here's our second secondary outcome. This is the composite of cardiovascular death or hospitalization for heart failure, our cardiovascular composite. There's a little bit more variability here. There's wider confidence intervals, as you can see, and there's lower numbers of events here. But again, overall, a consistent effect with no statistical difference between these results. And then our third secondary outcome, all-cause mortality, overall effect, and then data by underlying disease etiology. Again, consistent p-value for interaction, not statistically significant. Now we need to balance this efficacy with safety. So we're looking now in the same format at safety outcomes in the trial. We're looking at the percentages of patients who discontinued treatment due to an adverse event and the percentage of patients who sustained a serious adverse event during the study. You'll see here more serious adverse events in those with diabetic nephropathy compared to other causes of kidney disease, but by and large, a reasonable balance between the groups within the disease etiologies. And most importantly, none of the patients without diabetes, so none of the non-diabetic patients had either or developed either diabetic ketoacidosis or developed hypoglycemia during the study. So we didn't have diabetic ketoacidosis or hypoglycemia in those going into the study without diabetes. Now, within the group of patients with the glomerulonephritidis, we had 270 patients with IgA nephropathy. And this group compares favorably with the size of previous trials looking at immunosuppressive therapies in IgA nephropathy. So here's our 270 patients in DAPA-CKD, 262 patients recruited into the testing study, 162 into the STOP IgA study. These were studies of immunosuppressive therapies in this disease. And so here's our primary outcome in the group of patients, the 270 patients with IgA nephropathy, a hazard ratio of 0.29, so a 71% reduction in risk favoring the dapagliflozin over placebo. So in conclusion, as we've already seen from this study, in patients with chronic kidney disease with and without type 2 diabetes, dapagliflozin reduced the risk of kidney failure, reduced the risk of death from cardiovascular causes or hospitalization for heart failure, and prolonged survival. In this pre-specified analysis, we've shown that these renal, cardiovascular, and mortality benefits are present regardless of the underlying cause of chronic kidney disease and regardless of the presence or absence of type 2 diabetes. And dapagliflozin was well tolerated with a safety profile that is consistent with that seen in other patient populations. I just want to finish by thanking all those who participated in this trial. These are just the names of those who sat on the committees, but there's a much broader group of investigators, national leads. Also like to thank the patients and their families for participating in this study. And these data are in press in the Lancet Diabetes and Endocrinology, and we hope they will be published very soon. Thank you very much for listening to me.
Thank you very much, Dr. Wheeler, for these exciting results. There are several questions, as you can imagine, in the chat. One of them relates to the exclusion of type 1 diabetes and why that was a specific exclusion criteria.
So I think concerns about safety and the increased risk of diabetic ketoacidosis in the type 1 population, we should say that there's an ongoing trial of empagliflozin, EMPA-KIDNEY, that I believe is recruiting patients with type 1 diabetes. So we may have additional data in this population soon. And there have, of course, been other trials of these drugs in patient populations with type 1 diabetes.
Another question for you, those without type 2 diabetes, what proportion had pre-diabetes? Was the A1C measured?
Yeah, it was indeed measured. It was measured at the screening visit and at the randomization visit. If we disagreed with the investigator's call on whether the patient was diabetic or not based on WHO criteria, so if both those baseline HbA1cs were above the WHO threshold, then we classified the patient as having diabetes and we analyzed them as if they had diabetes. Regarding the rest of the patients who didn't have type 2 diabetes at entry based on WHO criteria, did they have glucose intolerance, mild diabetes? We haven't looked into that in great detail yet, but hope to publish on that at a later stage, because I think there've been similar criticisms of the DAPA-HF study in terms of, are we just dealing with a group of patients who actually have mild diabetes? We don't think so, but we'll look at those data in more detail.
And a question for you about, I think you mentioned that 20% of patients had a biopsy. Have you looked at those who had biopsy-proven GNs to see the efficacy of the drug?
No, that's a great question. So the biopsy data are not terribly detailed. What we asked the investigators in the case report form is whether or not the diagnosis they made, so the call that they made on the etiology of the kidney disease, was supported by biopsy evidence. But we don't have the details of those biopsies. We don't have the biopsy report. So it's difficult to dig into that in any more detail. I think we're fairly confident that those patients with IgA nephropathy had IgA nephropathy, for example, but we haven't got detail on all the other subgroups.
Questions about the impact on proteinuria in the subgroup that had glomerular nephritis?
So all of these patients, remember, had proteinuria. Albuminuria was an inclusion criterion for the study. So we're dealing with a group of patients with eGFRs between 25 and 75, ACRs between 200 and 5,000. And so we're only dealing here with proteinuria patients. What happened to proteinuria in those subgroups. We haven't presented those data yet, but we will be looking into changes in albuminuria in a future analysis.
Thank you. And will you be subgrouping by low levels of albuminuria versus higher levels at baseline?
Well, yeah, I mean, we in the primary publication in the New England Journal, we have actually stratified patients by the entry UACR lower or higher than 1,000 milligram per gram, and we saw no heterogeneity of effect on the primary outcome in those who went into the trial with the lower versus the higher levels of albuminuria. So a consistent effect across at least those two subgroups of albuminuria.
Terrific. And can you comment about the effect on blood pressure and whether that was a factor with the groups that, since the non-diabetic CKD, the glomerulonephritis group had a lower blood pressure at baseline? Can you comment about that?
Yeah, I mean, they had lower, those with glomerulonephritis had lower blood pressures at baseline. The blood pressures were actually balanced between the two groups, the DAPA versus placebo. Of course, that was on entry, that was the pre-treatment. We haven't actually analyzed blood pressure data during the trial in any detail as yet, but we will be looking at blood pressure. And obviously there's an interest in whether some of these benefits are mediated by blood pressure reductions. And we know that in type 2 diabetic populations, these drugs lower blood pressure. So it is possible that some of the benefits are linked to blood pressure reduction.
Terrific. And within the non-diabetic kidney disease group, there was not a significant impact, I believe, on cardiovascular mortality and heart failure. Was that just driven by the low event rate?
So I think we should remember that this trial was stopped early by the Data Safety Monitoring Board. We actually only accrued 2/3 of the events that we plan to accrue, and only 2/3 of the events that our power calculations were based on. So we lacked power. And I think that shows when we look at numbers of events in some of those subgroups. And yes, you know, there is heterogeneity and variability for that cardiovascular outcome. Agree with that. It's not statistically different according to the P for heterogeneity in that analysis. And if you look at the numbers of events, particularly in the non-diabetic population, then there weren't that many events. But remember that all-cause mortality was reduced in that non-diabetic patient population. So we're doing something right here. We may just not be particularly good at picking up, you know, causes of death in these patients. And the cardiovascular events, that composite was driven by heart failure more so than cardiovascular death.
Maybe one last question for you to comment about serious adverse events and those that didn't require, what were the serious adverse events that didn't require discontinuation?
The serious adverse events that didn't require, I mean, there's a whole variety of issues here, as you would expect in a group of patients with advancing chronic kidney disease and diabetes. I mean, I can tell you what we were looking out for and what we didn't see, and that was amputations. We didn't see an imbalance in amputation rates, and we didn't see an imbalance in dehydration, so in overdiuresis leading to issues related to dehydration. So we didn't. The answer is a variety of different events were captured in those serious adverse events. We didn't see any imbalances, particularly in those that we were looking out for quite carefully.
Thank you very much, Dr. Wheeler. That ends our Q&A portion of the session. And I'd just like to give a thank you to all of our speakers for excellent presentations today. We thank the audience for their questions and their engagement, which really contributed to an outstanding session. It's an extremely exciting time in nephrology to finally have additional options for the treatments of our patients. And I'd like to give a special thank you to my co-chair, Dr. Deidre Cruz, for her support and for moderating a wonderful session. Thank you.